Hello, and welcome to the Johns Hopkins University Pandemic Data Initiative's first expert forum. Today, we'll focus on the future of government public health data management and the changes in data infrastructure that will be necessary to prepare us for the next crisis. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health and a leader within the Johns Hopkins Coronavirus Resource Center. Over a year ago, Johns Hopkins launched the Coronavirus Resource Center to collect, report, and analyze COVID-19 data from local, state, and federal government agencies in the US and around the world. Millions know us for the worldwide map that provides real-time data visualization of the pandemic. The overwhelming positive response and traffic to this first of its kind effort revealed just how critical these data are and how much interest the public has in data to inform important decisions in their daily lives. But our work has also revealed a major shortcoming. Everyone interprets and manages this data differently. And that's what inspired us to start the Pandemic Data Initiative, with the goal of highlighting all of the lessons surrounding public health data that we've learned from the COVID-19 pandemic. We're especially interested in how we can best prepare our data infrastructure to prevent and address future health crises. Today is the first of several forums we plan to host to discuss what worked in COVID-19 public data management, what didn't work, and how to improve the processes moving forward. As part of today's forum, we'll have an opportunity for Q&A with our speakers, so please submit questions for our experts in the window that you see at the bottom of your screen. I'm now going to introduce our panel. I'm joined today by 4 guests who will speak to every level of public health response. First, Beth Blower is Associate Vice Provost for Public Sector Innovation at Johns Hopkins, and she's the data lead for the Johns Hopkins Coronavirus Resource Center. She'll be speaking about pandemic data, the important role of state and local data reporting, and why we're convening this forum today. Next, we'll hear from Dr. Leticia DeRaza. She is the Baltimore City Health Commissioner and the city's chief public health advocate. Dr. DeRaza has worked with Johns Hopkins throughout the COVID-19 pandemic to develop sophisticated data mechanisms to aid her agency's work. Then we'll turn to Amanda Daflos. Until very recently, she was the Chief Innovation Officer of Los Angeles, and she played a key role in LA's COVID response. She's now the inaugural Executive Director of the Bloomberg Center for Public Innovation at Johns Hopkins. And finally, Dr. Josh Sharfstein is Vice Dean for Public Health Practice and Community Engagement at the Johns Hopkins Bloomberg School of Public Health. Dr. Sharfstein brings a breadth of public sector experience that spans the local, state, and federal levels. He's the former Baltimore City Health Commissioner, the former Maryland State Health Secretary, and a former Deputy Commissioner of the FDA. Thank you all for joining me today. Beth, I'm now going to turn to you for a brief overview.
Thank you so much, Lainie, and thank you for everyone for joining us for our inaugural Pandemic Data Initiative Forum. I'm just so excited to finally have this opportunity and platform to talk about one of the things that has been at the center of my life for the last 18 plus months as we've been navigating the pandemic through the lens of COVID data. I don't think a lot of people understand the transformational moment that we've experienced as a global community, but also most specifically as a national community around pandemic data collection. Never before in my many years as working as a data nerd in the public sector have we ever had this moment where we had cities that were out there collecting data, states that were collecting data, ushering data through systems, sharing that data with the federal government, but also most importantly, sharing that data with the public. Not only did we at the CRC have millions of people coming to our site regularly to figure out what they were going to do to inform personal decision making in their lives, whether they were going to wear masks to the supermarket, whether they were going to engage in public life. This same data that was fueling those personal decisions was also the fuel that was powering some of the decision that we saw within the public sector. So today's conversation is so incredibly important because it really is the context for which some of the most important disease suppression decision making, the controlling of COVID, the proliferation of COVID resources, everything from testing to vaccination, was all rooted in this important data. And I wanted to talk a little bit about how the data actually came to life, particularly for us. All the data that you see, particularly depicting COVID in the United States within the CRC, is data that we derive from public data sources. These are cities, states, counties, public health agencies that have been doing something completely out of the ordinary, and that is collecting massive amounts of data on the health of people and sharing it almost immediately with the public. Typically, these processes actually root through very many other methods. They are collected at a program level, they are vetted through state processes, they are then reported to the federal government. The federal government then spends a significant amount of time reviewing data, making sure that it's reflective of their view of what's happening on the ground, and then sometimes months, oftentimes years later, that data is then shared with the public and then back down into local government. COVID changed all of that. The data was being released, it was being used, it was being applied to policy decision making within minutes of its arrival onto the front steps of city halls, governor's offices, health agencies across our country. And so it is really important for us to take a moment just to appreciate what a departure from the regular way that data has flowed. The other thing was there was no system in place, neither at the federal government or in state and local governments, to aggregate all this information so we could see a national picture. And Johns Hopkins University really played a pivotal role, particularly early on in the pandemic, as being that system and source of record. And we continue to power some of the most important decisions that are happening across the country, rooted in the way that we're collecting this data and that this data is aligning to the still very difficult decisions of whether schools are opening, whether our businesses are opening, what our life is going to be like, our public life is going to be like now and in the coming months. And so first, I just want to say that I'm just so excited to be here. I'm so excited that we're able to have this platform to talk about the intricacies of collecting this data, the application of this data, the decision making. But I want to kind of wrap up on one final note, and that is we're at a pivotal moment, and we're seeing a lot of states in particular make a different kind of decision around whether or not they continue to support pandemic data collection and dissemination. And what we're seeing is a lot of states are slowing down their collection of that data. So they were collecting that data every single day, and they were making daily reports. Starting last summer, really, last fall, we really started to see a slowdown where some states made the decision to not report that data over the weekend. But in the last several months, we've seen an acceleration of that decision making where states are making the decision to sometimes report just a couple times a week, sometimes to report just once a week, and some not even to report at all, and to be deferential to data that's being aggregated at the federal level. And it's incredibly problematic. It raises a lot of concern. And so one of the reasons why the Pandemic Data Initiative is so important is we are advocating for the data collection to continue. We are not yet out of the woods. And I know that our panelists will all talk about the sense of urgency that we feel. But I think that this conversation is just so important for us, not only to echo the importance of continuing, but also how can we leverage the way that we've been collecting public health data over the last 2 years, not to put the genie back in the bottle, but to think about the future of public health and the investments that we're making in public health data as we really architect a path forward for all of us. So I'm going to turn it back over to you, Lainie, but I just wanted to thank everyone again for being here, and I encourage everyone to read our blog at the Pandemic Data Initiative, and certainly tune into our forum.
Thanks, Beth. I'll now turn to Dr. Leticia Jaraza to share her experiences with public health data while running the Baltimore City Health Department during the COVID-19 pandemic.
Great. Thanks so much, Lainie. And thanks to my esteemed co-panelists. I really appreciate the opportunity to talk about such an important topic. Even from the very first cases of SARS-CoV-2 in late 2019, I think we all watched as pandemic data permeated through popular culture, right? If you click on CNN now, at any given time, you can still see the national and global case count, death count, and vaccination counts just ticking away. Data has become a constant in the news and on social media. I think rarely, if ever, has health-related data been so available to the general public, at least not at this magnitude. And because of this, I think local public health really had a heightened responsibility to communicate and interpret these figures to our communities in a way that is easy to understand. And Baltimore City did just that with our COVID-19 dashboard launched in May of 2020. We also work through media outlets like press conferences. But it was always important to me that we make our COVID-19 metric data transparent and easily navigable, and that we call out both the concerning and positive trends in our data. I think our dashboard was a huge success in demonstrating that we can share this type of disease data in near real time, allowing the public that insight into how policy recommendations and decisions are made. Our surveillance data was also very integral in driving our planning for testing and vaccination clinic locations. So for instance, here in Baltimore City, early on, we saw much higher case rates in a particular zip code, largely affecting our Latinx population. So we subsequently put one of our first mobile testing sites in this zip code, with subsequent expansion throughout the zip code as additional clinical and community partners provided support. Not only were we able to provide testing, but we were also very intentional about working with our partners to provide the wraparound services that we knew this community needed, so that our community members could safely isolate and quarantine. So while we do remain data-driven, I do just want to also emphasize our need at the very core of our values to also be community informed. So it really is the give and take of both at the local level. Likewise, for vaccinations, we've done something very similar. We created a framework with an equity focus, and we developed value leads that are designated to particular populations that we knew had already been hard impacted by COVID-19 based on the data that we had. So even now on our dashboard, we have a map that provides areas throughout the city with the lowest vaccination to highest vaccination coverage. And as we're planning our mobile vaccination clinics, we're looking at that same map that we're presenting to the public to understand where the needs are greatest. Our data was really necessary in leveraging those community assets that were already in place and in allocating resources where needs were greatest. It is very helpful for us to be able to show a legislator a map of a particular area with low vaccination coverage. That easily gets them on our side to help with canvassing and to help with outreach. So that has been so fundamental, I think, to how we've been able to do a lot of our work. We've really been able to translate that data into policy change and meaningful stakeholder engagement with development of subsequent action plans. So I echo what Beth says. We have to continue sharing this data in real time. And my hope is that this will expand and not just include COVID-19 data, right? Which is of course at the top of everyone's mind, but will also go to many other public health issues that we know exist. So thank you again for this opportunity to speak to this group.
Thanks, Commissioner Terraza. I have spent a lot of time with Baltimore City's COVID dashboard, and I'm a big fan of that work, so thank you. I'm now going to turn to our next expert, who has a lot of experience with city leadership during the COVID-19 pandemic, and that is Amanda Daflos. She's going to speak about her experiences with data while serving as LA's Chief Innovation Officer during the COVID-19 pandemic.
Great. Thank you so much, Lainie, and thank you to all of my esteemed panelists for the invitation to participate today. My role in the city of Los Angeles was Chief Innovation Officer up until very recently. And during the COVID-19 pandemic, I was tapped by the mayor and the city leadership to really drive our data, research, and science efforts. Some important context for Los Angeles is that Los Angeles City is one of 88 cities in the county of Los Angeles, and only 2 cities within the county have their own public health department, and that's Pasadena and Long Beach. So Los Angeles City, a city of 4 million people in the county, we don't have a public health department. So we work very closely with the county public health department, a very important collaboration during the course of the pandemic. But for the city, was tapped to really drive a lot of the efforts to be sure that our residents had eyes on and a complete understanding of how COVID was affecting the city of LA. So with that, And one of the very first things that we did last March was set up a data dashboard. And we drew heavily on the model of the Johns Hopkins work, and really piped a lot of that data into the work that we were doing in Los Angeles to give a global view, but then also to be sure that we had a local view. And in our partnership and collaboration with the county public health department, which we set up right away, I think one of the most important features any city, county can do going forward in a pandemic is be sure that those collaborations are very strong. We were able to develop some of the local data collection pieces that were necessary to be sure that we could track not only cases and deaths, but other really important information that was focused on things like equity, focused on things like gender. So we really had a sense of if more women were being affected by COVID or even dying from COVID than men. Part of how we used this information in Los Angeles was certainly in the ways that now, in my opinion, have been groundbreaking in terms of informing the public. But part of the ways that we did that in Los Angeles right out of the gate in March was that our mayor, who's one of the most visible figures in the entire Southern California region, really used the information in what were daily briefings. So every day at 5 o'clock, Mayor Garcetti would appear on the news, and we had millions of viewers just from the evening news. And then, of course, there are people that would watch it on rerun in the evening. And I bring that up because we use that as a very important way to be sure that not only did we have the data, but we were explaining the data to our residents, and that we were talking about patterns and building trust with the public, knowing that we had a really long road ahead of us. So it wasn't just a dashboard, but rather it was a dashboard that came to life every evening on the news for people. And we did that through the course of the summer. I think we did something on the order of 90 plus briefings. And we would always direct people back to the dashboard, back to the data, back to Johns Hopkins to, again, really understand the way that that COVID was affecting Los Angeles, particularly given that we were a city that was most impacted at different outbreaks in the course of the year. I'll note that there were some really important ways that we used data to really drive policy. I think this was, to Beth's point and to Dr. Duraz's really important point, one of the first instances that I can remember in my lifetime where data was being used real time to drive policy. And masks are a really good example. Last April, May, the city of Los Angeles, we were all trying to figure out if masks were the right thing, as was our county. And so in collaboration with the county and in collaboration with a lot of leaders in Los Angeles, we took the step to mandate masks. But we did that not necessarily based on US data, because at the time, COVID was so new in the US that we looked to Asia. And we looked to other places where we could find documented evidence from past outbreaks that indicated that masks could actually be useful. And that led to some of our early requirements on masks here in LA. And I think to this day, we see high compliance because we used the data to communicate the need for masks. And of course, there's a broader conversation around masks, but it helped to really illuminate the effect of masks and the ability to use it as a tool to prevent and actually remediate COVID. So those are some of the ways that we use data in Los Angeles. And I think, some of the things that we learned out of our experience, I think everybody learned so much, but data has changed the conversation around public health. It has changed the conversation around government. And I think this past year has illustrated how we can use it to really build public trust and in times even lose public trust. So it is one of the most important tools I think we've really seen in that way. And so those collaborations with county, collaborations with state, I think are some of the things that as we look ahead will just be so critical. And then the last point that I think I would raise and that we learned here in Los Angeles is one of the most critical things that we can do as we go forward is look at how we upgrade our systems in government and not lose this moment to be sure that we really can pipe all the information in from the local level to the state, to the federal government, so that we can do things like look at the Delta variant locally and be sure that we're elevating that to state and federal authorities so that we can actually gain and garner the support. That real-time data is just so instrumental on even things like outbreaks, things like contact tracing, things like being able to pull lists from flights to be able to respond in a way that's meaningful and urgent and fast. So again, thank you so much for the opportunity to be here. I'll turn it back to Lainie at this point. Thank you.
Thanks, Amanda. And before I turn to our final speaker, I want to remind those who are watching, please submit questions for our expert in the box that you see at the bottom of your screen. After we hear from our next speaker, we'll move into Q&A for the remainder of this session. So I'm now going to turn to my colleague, Dr. Josh Sharfstein, who will share his thoughts and experience with public health data on the front lines from nearly every level of government.
Thanks so much, Lainie, and thanks so much to Beth and the team for including me. It's an honor to be on this panel. As Dr. Jaraza knows, I'm a super fan of her work in Baltimore City during the pandemic. I'm also followed along the tremendous work being done in Los Angeles. So, in public health, we have this big challenge, which is having people understand what we do, understand the challenges, understand the decisions, and ultimately be supportive of critical actions to protect health and save lives. And I think the COVID pandemic has brought a new understanding of how important not just data is, but the use of data and the transparency of data is to that fundamental mission of public health. And I'll give a few specific examples in how I think about this. A big challenge we have in public health is getting people's attention. Well, it was, the Johns Hopkins dashboard got people's attention about the spreading virus. And in each city, great dashboards like the Baltimore City one kept people's attention every single day. What happened? Who is it happening to? What's happening with hospitalizations? What's happening with deaths? I had more sophisticated conversations with people about data on COVID, by a mile than on any other public health issue because the data was there. And with attention, that means people are ready for the conversation of whatever it is to follow. You've captured their focus. The second thing, and there's been some mention of this, but I'll put a little finer spin on it, is that it helps to explain policies. But let's be honest, this has been a very difficult pandemic for explaining policies. And Dr. Jaraza has been in the position multiple times where Baltimore City has taken a different direction than some other places in the state or the governor. And I've been a witness to some of the press conferences where the mayor was asked, well, why is he doing something differently? And his first answer is because Dr. Jaraza advised him. And his second answer when pressed is because this is what the data tells him to do. And the fact that people understood what the positivity rate meant or the changes in infections, that allowed for a very strong defense, not just in the court of public opinion, but in court. And at times when particular restrictions were challenged, the evidence was really what made a difference in court. And Johns Hopkins experts, others testified to the fact that what the city was doing was absolutely justified. Third thing is that the expectation of data allows people to be suspicious when the data is not forthcoming and actually help to more rapidly identify flaws in the response. And the example I would give here is that the state of Maryland really set out the goal of equitable distribution of vaccine. But when the vaccines were not being delivered equitably, there was a data gap to explain, well, what happened? And the state really was unable to provide data to explain that. And that really fed a great deal of understanding that there was something missing. How could it be that the goal is equitable distribution by county, but there was a threefold rate in variation early on in actual vaccination by county? And pointing out those data gaps, I think people were ready for because of the understanding of data. And that led the state, in my view, to take this issue a lot more seriously and make a series of policy decisions focused on better distributing vaccines equitably. And the next topic I'll talk about briefly has to do with equity. First of all, just getting data by race, ethnicity is just a huge step. And understanding the need for that became very apparent in the pandemic. I know Johns Hopkins put up maps of who wasn't sharing data in this way. Just the availability of data, it rendered invisible questions visible, which is very important. But it also became clear that it's not just the raw numbers. It's very important to explain and review and put them in context for people. And here I've mentioned a national issue, which is that the CDC had data by race ethnicity up pretty early, but they were not adjusting it for age. And it so happens that the white population in the United States is much older than the population of other groups. And so they were going to look in an unage adjusted way, much more heavily, relatively heavily affected by COVID. But if you're really comparing on the basis of race, the CDC standard practice is to adjust by age, which they were not doing. And it required, raising that issue for CDC finally by December 2020. So that's how you wound up with this weird situation where the whole year they're saying, maybe there's a 20% increased risk. They weren't age adjusting, but suddenly seeing a 3 to 4-fold increased risk and a major decline in relative life expectancy for African Americans and Latinos compared to whites, because life expectancy is age adjusted when it's calculated. So it really is important to make sure, particularly when looking at these questions of equity, that the appropriate studies and comparisons are done. And I'll just conclude with a really important point I think that Amanda made about trust, because this cuts both ways. Data can improve trust, but the absence of trust can make it harder to get all of these advantages with data. And this whole enterprise kind of rises or falls a little bit on whether people are able to have confidence that the information that they're seeing matters to them. And this kind of attack on the integrity of public health agencies, on who you're going to believe, the data, or I guess I have to figure out how to say that, me or your lying data eyes, so it is a big threat to this. And so I see that what Beth said, this kind of urgency. I mean, I just did an interview where I said, people said, well, overdose deaths are at their absolute highest. What should we do? I mean, we should take a page out of the COVID playbook. We should have much more urgent data. I mean, people are writing now about the peak in overdoses that happened in 2020. It's July, a whole other 6 months have gone by, right? For COVID, we knew when that happened, like the next day. So we should be bringing that urgency, bringing all these, advantages of data into other issues. But the headwind we're facing is whether people trust it. Thank you.
Thanks so much, Josh. And before I transition to Q&A, I want to remind our viewers that there's a banner on the screen that will take you to the Pandemic Data Initiative portion of our website, which has a wealth of information. Also, if you think of questions for our experts as we move into Q&A, please do post them. I am actively keeping an eye on the chat throughout this session. So, Dr. Jaraza, first question is for you. Amanda mentioned that more women in LA were dying of COVID. What types of trends did you see relative to sex or race in Baltimore from looking at the pandemic data?
Yeah, that's a great question. I mentioned that our dashboard early on, we wanted to point out what disparities were that we were seeing internally and make sure that the public was widely aware. So some of the early trends, we're seeing much higher rates in our Latinx population. It's a smaller population here in Baltimore City, only about 5% of our residents, yet they had significantly, at one point, 4 times the rates compared to whites. So this is a pretty stark contrast for this group. So that was something we saw early on, and again was one of the reasons why we launched into this is where we need to do our mobile testing, right? We need to detect disease early in this population and then provide them with the resources to safely isolate or quarantine. Additionally, we've always seen that the rate of death is higher among African Americans here in Baltimore City with regards to COVID-19. And so again, I think For us, we also took the form of how do we talk about this on social media? So on some of our other outlets, how do we break down this data in a way that people understand and can follow, right? Like it's happening to your grandparent, it's happening to your neighbor. And so that translated into how we did some of our kind of mass media campaigns around who was getting COVID and who was dying from COVID. We're seeing, unfortunately, similar trends with vaccination rates, right? Where at the beginning, when we kind of first began vaccinating, whites had about 4 times higher vaccination rates compared to African Americans. We've seen that divide narrow some as time has gone on, possibly in part to just much more expanded eligibility and improvement in access. But again, we saw these trends early on, and so had to be very intentional about how we have approached our programming, how we provide testing resources, how we provide vaccination resources, and in what communities that we go to.
Thanks, Commissioner Jaraza. I'm now going to ask a question of Beth, but I do invite our other panelists to weigh in after Beth gives an answer. So Beth, given the new practices in this culture of more robust data collection and representation that we've been talking about, how do you see this potentially translating to other critical issues, especially for urban areas?
Yeah, I mean, I think Josh made a really good point in his comments that the same kind of infrastructure, imagine if we had real-time information on overdose deaths, where we would be able to do this kind of granular geographic analysis of where they were occurring. We could get safe practices in place for active users. We could do intervention work. We could be much more targeted in our outreach. All of those things become very difficult when you're dealing with a 6 to 1 year lag, 6 month to 1 year lag on that data. You completely lose the ability to do those kind of strategic interventions, and you end up relying on mutual aid and word of mouth information, which oftentimes then also thinks about cast doubt on the capacity of the government to actually intervene and support recovery and intervention. I think that we should be doing the same thing with student performance. We should be doing the same thing with our climate challenges that we experience in our cities, with how individuals access services with our cities, and most importantly, our comorbidity data, which would have been a very great resource to have throughout the entire time that we were thinking about COVID data. We knew that people that had some of the really complicating comorbidities were at risk for some of the most serious effects. That data is on a 2-year lag that comes back to our local health departments, people that are on the ground that are trying to reach people. And as we know, particularly our most vulnerable populations, they are transient. They're not necessarily, they have ebbs and flows in their healthcare. All of that information with a 2-year lag made it virtually useless as we started thinking about whether or not we could target particular populations or communities based on that comorbidity information. And so there's a wide range of ways that we could be leveraging more routine and regular reporting of data to really get at the root of some of our most systemic challenges that we face as communities. And COVID showed us it's possible. And now the question is, do we try to put the genie back in the bottle, or do we actually try to take this infrastructure and these newly built skills that we've been building in the public sector and actually nourish them so they can start really widening the effects that they can have across a number of different outcome areas?
Thanks, Beth. And I saw our other panelists nodding along with you. And since this is such a wide-ranging question about how interest and these more robust data infrastructures may translate to other areas moving forward, I am going to see if anyone else wants to jump in with additional thoughts here.
I mean, I'll just say that I think the various types of data each have implications, so there's the reported data, there's data that comes from the healthcare system, there's, there are all kinds of sources of data. Each of them have different types of relevance for the future. And setting up, some of these data sources really can only be turned on when there's just a massive special reporting effort. But other data sources are there, just sitting there, and could be streamed into public health, on a regular basis for particular appropriate purposes. The legal framework is there to do that. It's just a question of, deciding that there are certain particular priorities, overdose being one, others, could come up, and then you could wind up with perhaps not, 12 channels of information, but, 6 good channels of information that really help both, drive attention and a policy response.
Thanks, Josh. Amanda, I'm now going to turn to you for a question about populations that are especially vulnerable or transient, including individuals experiencing homelessness. So it feels like there's been a gap in data collected for these individuals, especially if during the pandemic, it was difficult to do contact tracing for them. Can you speak to how this was handled and also how it could potentially be addressed going forward?
Sure, yeah, happy to. And I'd love to talk about that. I did want to note that I think at some point it was mentioned that women were dying more frequently in Los Angeles from COVID. And it was actually the opposite. It was men were being admitted to the hospital more frequently in Los Angeles and also dying. So I just wanted to correct any confusion that I may have raised about that. But so to note that. And then in terms of vulnerable populations, Los Angeles is, again, a population of 4 million people. In our county, we have 10 million people. And it is estimated that we have about 85,000 individuals who are experiencing homelessness in Los Angeles. So the number is broad, and the number grew during the pandemic due to a lot of the economic impact that the pandemic had. And what I would note is that, we had street teams. And I think other cities sort of mirrored that pattern of having street teams that were reaching out in particular areas where there are a lot of individuals who are experiencing homelessness. For us, it's in downtown Los Angeles. And then there are places throughout the county that have other concentrations. But these street teams are really focused on being able to ensure that those experiencing homelessness had access to services, had access to information, and we're also being, to the extent that we could be surveying individuals to be sure that we had a pulse on what that outbreak might look like. I will note that as we transition, and so for testing, I'll note that for testing, we also put testing facilities in areas where there were high concentrations of individuals experiencing homelessness to be sure that testing was available citywide, including to populations that might be moving more frequently or again experiencing homelessness. So we use the data to actually, to some extent, we know where those concentrations are, but to other extents, we were able to really narrow in on zip codes as far as people regularly experiencing homelessness. Where there were outbreaks in partnership with our county, we were also able to look at, to the extent that we could be really specific, where there were outbreaks happening, putting testing in all of those areas and ensuring that people, again, had access to testing. As we moved into vaccines, the city and the county, the city ran a lot of the vaccination efforts, including big sites like Dodger Stadium, but then also really importantly, again, foot teams. And so we had teams that were, especially now as we get to the point where every vaccine is harder to actually get, but early on, putting vaccination centers around the city. And then we had a mobile operation as well. So that mobile operation was standing up for maybe a week at a time in a zip code or in an area where there were individuals who needed, or perhaps were transient, and so needed access to vaccines in a much more fluid way. And that was actually quite effective in terms of getting individuals vaccinated. Also putting those mobile teams at our homeless shelters, putting those vaccine teams at any place where individuals might be seeking services that they wouldn't otherwise get. And we also made, on a lastly note, we did a lot of things in Los Angeles, but I'll note that one way that the data was just so helpful was, again, this idea of looking at zip codes, getting down to the extent we could, street level, but then also looking at using that information to actually make vaccines available in certain heavily impacted populations more quickly. So early on in the pandemic, January, February, at least here in California, there were age limits. So it was seniors first, and then we went into this sort of next band of individuals that could be, that could access vaccines. And so we used that zip code data paired with those, for lack of better words, rules, and as soon as we could open it up, we opened it up more widely within areas that were heavily impacted. So for example, in the zip code 90018, which is where I live, it's a zip code that experiences a lot of different factors that make the zip code more available, or that we chose to make 90018 a zip code where anybody could get a vaccine all the way back or as early as March. That was a partnership with the county. It enabled clinics in that zip code to just make it available to everybody because we knew that people were more volatile in that zip code. So I think just some examples on how we chose to tackle both the upfront testing piece, but then also the vaccines and all the other aspects of COVID along the way for those populations.
Thanks very much. And Commissioner Jaraza, since this concerns real-time response, I want to give you a chance to weigh in on this one as well. So can you please speak to ways in which data was helpful or potentially data-related challenges for populations that are vulnerable and transient, like individuals experiencing homelessness during this pandemic?
Yeah, I think for us, certainly monitoring the data at the zip code level, but we actually work very closely with congregate settings. And so working very closely with our Mayor's Office of Homeless Services and those organizations that run congregate settings and getting access to HMIS, which is the system used by many of these organizations to understand their population so that if there was a positive case, we actually had strike teams similar to what Amanda described that would go out and test an entire center, and then subsequently, if needed, relocate individuals to an isolation or quarantine hotel. So we use kind of the information we would get from those centers to perform outbreak or surveillance testing using our strike teams. Likewise, as we establish our isolation and quarantine hotel, we had the relationships established so we could set up vaccination clinics with those centers and at the actual hotel where we serve residents.
Thanks, Commissioner Jaraza. Beth, I'm now going to ask you about a question that I know is very close to your heart, which is how do states vary or prioritize which demographic factors they're collecting during COVID-19?
Yes, certainly an issue that's very close to my heart. Very early on, in the spring of 2020, we knew that anecdotally there was a lot of disproportionality in the effects of the disease, and it was being driven by demographic information. But this was all anecdotal. We were hearing it from cities and states, and so we started to first figure out where were the places in the country that were actually sharing the COVID data, but also breaking it down using demographic categorization. It turned out it was a very small sample. It was only a handful of states. And so one of the first public data visualizations that we actually published on the CRC was a map of the United States that had the states that were breaking down their data, whether it was case data, death data, or testing data by demographic information. We launched that in April of last year, and within several weeks, we had almost full coverage for cases and deaths. So we really, I think, was one of the real effects of our work at Hopkins has been on encouraging the kind of reporting that's happening in states. So we got a lot of states using their capacity to share the data and break it down by both race and ethnicity, and also gender and age in many cases. The complication is that in the lack of a universal standard for how that data should be described, the demographic data got incredibly challenging because states don't necessarily use the same demographic language in the way that they describe populations. And so I'm going to give you an example around vaccine, which I think is a stunning example and which we've talked a little bit about in the PDI. Which is that just for vaccine dissemination across just the 50 states, we have over 1,000 different ways that we're depicting race and ethnicity, just in the variables that we're using to talk about the definitions. That doesn't even account for intersectionality. It doesn't account for some of the other ways that race has played. And so these are huge challenges that even when we have the release of that data, it becomes less and less useful when there is an inability to actually do the kind of analysis that would get to the root of what are some of these more entrenched disparities that exist within the public health system. And so the demographic data continues to be an enormous challenge. We're trying to do a better job at sort of talking about that challenge, as we're also trying to do a better job of releasing that data. But it does and continue to be one of the areas where I think we need a lot more federal leadership in terms of just helping us create that standard so that we can start aligning the way that we do these collections across all programs. This is not unique to COVID. Demographic data is in disarray in many other places that we think about the social determinants of health and some of the other things that really contribute to outcomes for people. And so while we got a lot of governments thinking about why it's so important to do this work, there's still a long way to go before that data becomes granularly very useful in shaping policy and the way that we think about decision making.
Thanks, Beth. And I'm going to follow up that question with a why question. And Amanda, I'll start with you. So why was having access to demographic data during the pandemic response helpful to you? Can you give some examples?
Sure. I would just go back to the vaccine example that I gave, which is to say that we were able to look at outbreaks in terms of outbreaks with zip codes and just general demographics. We were able to then sort of pair that with vaccinations and find a way to deliver vaccinations to communities that were having outbreaks among certain populations, which we knew from that demographic data. I also think it changed the narrative, certainly at the national level. It changed the narrative at local level too, in terms of understanding who was being impacted by COVID most. And I'll go back to the example of male versus, or just the gender data. Which is to say that we were able to lift up this idea of the fact that men were experiencing COVID more often and dying from COVID more often, and actually prepare city leaders, prepare public health leaders to have that conversation in the briefings that both the county and the city were doing. So we were able to actually say, hey, men, the numbers show that you should put on a mask. Maybe you're wearing masks less frequently. Maybe you're out working on the front lines more often, but just know that this is what's actually happening. And I think that it changed the way people in Los Angeles, the way men in Los Angeles experienced COVID and the actions that they chose to take for themselves. So I would note that. And then I think the third and maybe final example I would give, there's probably a long list of examples, but same with testing data. We were able to look at all those pieces as far as demographics go and know in that way who is experiencing COVID, but also who is going to get tested more often for COVID. And again, in Los Angeles, the case was that women were getting tested more frequently. Now, whether that was because they were taking action for their own health more often, or it was because they were sick more often, and we were able to demystify some of those kinds of questions and share that with the public so that we could also communicate to the public that they should take action if they weren't feeling well, again, particularly with men. So I think there are a lot of really important places where gender data mattered, age data mattered. What Josh was mentioning with respect to the sort of this question of age pieces on vaccines, that happened here in Los Angeles. People felt very passionate about the fact that more white people were getting vaccinated. But in the end, we were able to demystify that a little bit by looking at the demographics and saying, well, actually, our population in Los Angeles, those that are 65 and older, which were all that was available, were eligible to get vaccines early on. We were able to demystify that a little bit over time to say that, the 65 and older population in Los Angeles happens to be more heavily white. And when we get into these younger ages, that will inevitably change. And then go back and actually talk about that as that happened, just to be able to have that conversation in a way that the public understood and also trusted us as far as what we were saying and then also doing.
Thanks, Amanda. And Dr. Jaraza, I'll give you a chance to weigh in on this one as well. If you could reflect on how demographic data was helpful to you during the pandemic response, and also potentially what do you wish that you had within demographic data that you haven't had access to?
Yeah, so thinking about that first question, I mean, I think for us, it allowed us to redirect resources that were limited to the places in highest need, right? So I think when we think back to the early days, if you can remember, access to testing was pretty limited, right? And so that really played a role into who got tested. And so once we were able to, have a bit more access to testing, we still had to be somewhat selective, right? And really go to the communities where the needs were highest. So again, knowing that, this particular zip code had high case rates, or this particular zip code just had low amounts of testing happening. This is someplace we should go. It really helped to direct our mobile testing strategy. I think likewise with vaccinations, again, maybe early on, because of how groups were prioritized, you might have seen vaccines skew towards a particular group. Now that it's open and everyone is eligible, drilling down a bit more into the data and understanding, okay, really now that everyone can get vaccinated, who is not getting vaccinated, and how do we then tailor our message to address that group specifically? So I think data has been very helpful in our work in that way. As far as data that I wish I had, and this maybe piggybacks on some of the things that Beth mentioned and some of the things that Josh mentioned early on, is not having kind of standardization in the data. One of the things that I like to do is kind of look across the country or look at similar jurisdictions to understand, how are they faring against COVID-19, or what are their vaccination rates, right? Like as the only kind of city and urban jurisdiction, mostly urban jurisdiction here in Maryland, our data is going to look differently from a suburban or rural area in the state. So it would be really helpful for me to understand, okay, how are cities that demographics are similar to Baltimore City, how are they faring? But oftentimes I go and they're recording data in a different way. And so, it's not really, you're not able to compare apples to apples. So I think that would be helpful for me.
Thank you. And we have a lot of questions coming in related to data standards, and sort of the theme here is, why doesn't the federal government just set data reporting standards? And then, as Beth, I think you mentioned 1,000 different ways that we've seen demographic data being reported in this pandemic. Why don't the feds just make it easy and tell everyone what to do? So Beth, why don't you start, and then Josh, I'll turn to you.
Yeah, sure. So it's a question that I have asked myself a lot, especially during an emergency. I think that there's a misperception that it wouldn't be welcomed by state and local governments. But I can tell you, like, from all the evidence of running the data parts of the work at the CRC and working with Lainie and others, there were lots of mayors and governors that were coming to us and saying, just tell us how to share this data in a way. They were desperate for the kind of advice that would come if there was a formal standard. And I think that it's important for us to keep that in mind, is that, first of all, there was a demand for it. It wasn't just that it would be a top-down way of trying to get information at a national level, but that there was some real need for some of that guidance. The reason why it's not so easy is because there are lots of really complicating regulatory frameworks that exist in the federal government that require certain data to travel from state government into the federal government in certain ways. And then there are regulatory frameworks that really dictate how that data leaves the federal government and comes back into state and local coffers. And the reality of the situation is that they are important measures that are built into some of that data sharing. Many protect privacy, many protect some of the quality of the data that's there, but for a large part of those that standard and that regulatory framework, some of it was architected before the internet. Some of it, there's a need to modernize the way that we think about data and data sharing between the states and locals and the federal government. That I think is now all of a sudden kind of an aha moment, both at the federal level and at many levels in state and local government, that we need to be thinking differently about how we functionally share data. It doesn't necessarily only have to be in these strict reporting cadences. We've seen ad hoc data sharing agreements emerge through this pandemic that have allowed cities to get data from their county health departments or from their state health departments and vice versa. There are other mechanisms for sharing data, and we really need to think about how we can first get the data to move, and then how we can get that guidance really in very clear terms shared from the federal agencies, so that way we can have that consistent reporting across landscapes. But I'm really interested to hear, Josh, your opinion on this, because I know that you've also have worked both in the federal context and the state context, and I think there's probably a lot in there.
Yeah, I think that what Dr. Terraza said about there being so much value to localities to being able to get standardized data and compare where they are with other places helps you overcome the problem you have, which is everybody shows up at a data meeting wanting to use their standard. You know, everybody likes the idea of data standardization because they've got the best standard. But then suddenly when they have to make a change, then they've got all kinds of people who are upset about it. And in some cases, there are legal barriers. In some cases, it's just we've always done it this way. And you can look at it with the pandemic itself. Like at the beginning, it might have been kind of easier at least to say, okay, this is what we're counting as an incident case, you know, and this is what we're counting, you know, whatever it is, you could have just said, that's what we want you to do. The federal government could have taken a lot more leadership, I think, up front. Now you're a year later and everybody's settled into their reporting. It's kind of hard to ask people to change because, you know, I'm sure you've, you know, at Johns Hopkins, you know, Data Central have figured out, you know, how to make adjustments or, you know, make notes to people so they understand how to look at the data, but everybody's sort of done that already. And then you'd have to just put all this extra time in to kind of reset at this point. So I think it's a lot harder to do when everybody's already up and running and knows what they're doing. But I do think it's worthwhile. And I also think you can prioritize. There's certain measures that would be just really helpful to know in a consistent way. And you know, even now, I think there'll probably be, you know, some advantages to making sure that those are really standardized, recognizing that there are a whole bunch of other things that you may never exactly get right. You know, how people report hospitalizations might be based on regional patterns and how people report, you know, the causes of hospitalization. So it's just going to be that might be much harder than a pure, you know, clear answer on who's a new case of COVID-19. But, you know, I guess my main point would be it's a lot easier to do when you're building it at the beginning.
Yeah, and I'll actually add on to that. You know, hospitalization is actually a really good example because there was a change. Like midway through, the federal government did decide to announce a standard for hospitalization data, and it was really disruptive, particularly for those hospitals that were, you know, in the midst of a surge of cases and dealing with all of the complexities of having, you know, a run on the data. But I will say, like,
their phone rang and someone said, "Great news! We now have a new data standard."
Yeah, exactly. But the reality is that hospitalization data is probably the cleanest, best data that we have across the nation because of that. And, you know, as it relates to COVID. And so there was a lot of pain. There continues to be a lot of pain. There was a lot of pushback. I'm sure there continues to be a lot of pushback. But it is actually, you know, a little bit of a conversation that has to say, like, but it is actually incredibly insightful information that's been very useful in thinking about these sort of policy levers that we have for intervention.
Well, thanks, Beth and Josh. And I think that's a fitting note to wrap up our first expert forum from the Pandemic Data Initiative. So I want to thank all four of our speakers once again, Beth Blauer, Amanda Daflos, Dr. Josh Sharfstein, and Commissioner Leticia Duraza for joining us today and for sharing your expertise. The insights that you gave us are critical, both for the current pandemic and also as we anticipate future emergencies. The next Pandemic Data Initiative Expert Forum will be on September 17th at 12 p.m. and you are able to pre-register for that event through the Pandemic and Data Initiative page on the Coronavirus Resource Center. I want to thank our audience for joining us today, and especially to those who sent in questions for our experts to answer. This session will be archived and available at coronavirus.jhu.edu. Until next time, thanks and stay safe.